Hello, and welcome back to Conscious Caregiving with L&L, where we're tackling the tough conversations. This month's topic is the bureaucracy of care and seniors. Welcome to another episode of Conscious Caregiving with L&L. I am Lance A. Slatton, your co-host and also the host of All Home Care Matters. Today we have an esteemed panel of specialists and experts, and we're going to be talking about the care of bureaucracy for seniors. So I'd like to start with having our panel introduce themselves. Amy, we'll start with you.
Thank you. I'm so excited to be here. Good morning, everyone. So over the past 30 years, as a physical therapist, I've been both a caregiver professionally, but also personally, many times over. And I've experienced the rapid changes in healthcare, in the healthcare landscape. So I've gained a deep understanding of the regulations, the dynamics, the blind spots. I've also seen and experienced myself the complexities and barriers that caregivers experience personally. And so I'm excited today to talk about that.
Thank you for being here. Well, Donna, we'll go to you next.
Thank you so much for having me. I'm Donna de Villiers, and I'm a Dementia Prevention Consultant. I've been working in health and social care here in the UK since around 2007. And I work with both sides, with the families that are looking to put care in place for their loved ones. And I also work with the families and all of the younger generations to put strategies in place to move towards reducing their risk of dementia for future generations. And it's been wonderful to be here. So thank you for having me.
Our pleasure. Thank you, Donna. Tracy.
Thank you very much, Lance. My name is Tracy Cram-Perkins. I am a 4-time dementia caregiving survivor and the author of Dementia Home Care, How to Prepare Before, During, and After. And it's my mission to teach caregivers how to make caregiving easier and how to survive caregiving.
Thank you for being here, Tracy. Dr. Ann.
Hi. Again, thank you for having me as well. I am Ann Kenny. I'm a geriatrician and a palliative care physician. I have lived the dementia journey with my mother and wrote a book called Making Tough Decisions about End-of-Life Care in Dementia when I looked for a resource to help my siblings as she stopped living well with dementia and began to die from dementia. I also work as a dementia coach at this point, and with a lot of the dementia people living with dementia in the early stages. They were looking for some way to plan more robustly. So I've just released a book along with Teresa Webb, who is a woman living with frontotemporal dementia, called Your True North, again, as a guide to help people make some of those planning choices about living well now and planning for their end.
Thank you for being here, Dr. Ann. Next, we'll go to Mary.
Hi, I'm Mary Farquhar. I have taken care of my husband, Roger Fisher, so I have designated myself as CEO of Roger Fisher Care, and I'm very happy to be here. Part of the reason I'm here is I'm in a support group facilitated by Lori, and my husband is a veteran, so I have navigated the VA system as well as the medical system. Thank you.
Thank you for being here. Malika.
Hi, I'm so excited to be here with everyone. I'm Malika Moore. I'm the owner of Aging and Amazing. We're a care management agency, and we have an online community that supports people all over. We specialize in putting the puzzle pieces of your care and aging journey together. I'm glad to be here.
Thank you for being here. And then it's my distinct honor to welcome our co-host, Miss Lori LeBay, who is the founder of Alzheimer's Speaks and co-founder of Dementia Map. Thank you for being here, Lori.
Well, I'm thrilled to be here. I love these discussions, and I can't wait for this one today.
Yes, it's going to be a good one. I'm going to start off, though, with Amy. And, today we're talking about the bureaucracy of care and seniors, and our healthcare landscape seems to always be changing, sometimes for better, sometimes for worse. But the one thing that does remain a consistent constant in the healthcare system is a lot of bureaucracy, red tape, things like that. I think anybody who has dealt with it has experienced it. How have you seen the healthcare system change over the years, Amy?
I think the biggest change that I've seen is that the health insurance has changed, like the understanding of what health insurance covers, what it doesn't cover, what the responsibility is of the patient versus the physicians or the healthcare provider who's providing your care. back many years ago, 30 years ago, it seemed more straightforward, right? You went to see your doctor, you gave them the card, the person at the front desk knew that you had a copay, you'd pay your copay and you'd be done. And it was pretty much cut and dry. Now today, it's the people at the front desk don't really even know what if you have a copay. They just confirm that you have your health insurance or you don't have health insurance, and then you wait for that paperwork to come, and then you're trying to figure that all out. And every year it changes.
Right. Have you seen it? What are some examples, if you have any, of things that might have changed for the better and then some things that might have changed for the worse?
So I do think some of the things that are for the better is that I feel that we're a little bit more as a patient, as caregivers or families, that we have a little bit more vested interest. Like we're having to understand it a little bit more, right? We're having to understand we have health insurance and what that pays for. Before, I mean, really, again, several years ago, it was more, oh, I have health insurance or I don't have health insurance. Now it's, I have health insurance, I have this copay, or I have a deductible, it's in network, it's not in network. What I think is bad now is it seems very siloed. And it seems very business-like, which I understand healthcare is a business.
Right.
However, it affects us as caregivers and our families, like my parents, for example, that I'm caring for right now. When my dad goes in to see the doctor, he asks them questions and they can't answer the question, where before somebody could answer that question for them.
Right.
And I try to explain to my dad that it's an office in a different part of the city that we can call and talk about his bill.
Yeah. So what would you say are some of the biggest obstacles that caregivers and, our aging population are encountering today with the healthcare system as it exists?
I think the biggest is just understanding that it is a system, and that understanding the regulations, understanding the rules, understanding how to advocate for what you have. So it's very, very important to have somebody there that can answer your questions about, do you have a basic, I'm throwing out some of these terms, but do you have a basic HMO? Is it a PPO? Is it straight Medicare? Is it straight Medicaid? And people just don't understand what that means and what the implications of that is for them as a patient or as a caregiver. And then when you're in the hospital, or you go to a physical therapist, or you go to see your dentist or whoever, you need to understand that. So you're getting all the care that you're supposed to be getting, and that it's paid for, for what you can have it paid for.
Right. And I just want to kind of piggyback on that. And you kind of alluded to it with, HMOs, Medicare, things like that. But I feel like a lot of the change, at least in my opinion, started with our health insurance companies, where the health insurance companies are now practicing medicine in a sense of letting the physicians know what they can and can't do, when they're not the medical provider, but they're letting the medical providers know what guidelines they must, operate or function within, which I think has really been a negative for our healthcare society and, for us.
Oh, absolutely. Because the person behind that decision making at the healthcare company isn't necessarily a clinician, isn't not necessarily somebody that understands what that means. I mean, I know even for myself many years ago that I got denied a gestational medication and test. And when I called, it was the person didn't even know what gestation meant. Right. It was for pregnancy. And that was my first awareness to, oh my gosh, yeah, who's sitting behind the desk making decisions for my healthcare?
Right. Last question before I go to Lori. Do you see this changing for better, or do you see it changing for worse as we go forward?
I wish I could say that I see it changing for the better. I think healthcare literacy is so important. And I just see, as soon as there's that expression, right? As soon as you know the answer, the questions change. I feel like that's part of it. And I'm not necessarily seeing it getting better. Well, I guess what I do see better is that there's all these wonderful people who are starting to have the same passion that we all have here. And we're starting to say, hey, we're putting a stake in the sand and saying, hey, enough is enough. and we need to do something about it.
Absolutely. Absolutely. Well, thank you for being here today. Lori, we'll go
Thank
to
you.
you.
Great. I love the term healthcare literacy. I think that is so important because it is. I feel like it's the chicken or the egg and the ball under the cup and trying to watch things all the time. So thank you so much, Amy.
Thank you.
Donna, I want to go to you because you are over in Scotland. And what the heck is it like over there for you? With what Amy is saying, does that resonate over there?
Oh, so deeply. I mean, the words are different. In Scotland, we have a social care system. And so we don't have HMO or insurance the way that you do on your side of the world. Everything here is done through a social system. But even being done through a social system, it's just so difficult to advocate if you don't know what exists. And that's what I find most of the people that I work with, they don't know what they can have. They don't know what they're entitled to. And the way that the system works is that it's basically, if you don't ask the right question, you're not going to get an answer. People aren't going to take the time to sit down and explain to you, like, oh, you're entitled to all of these things. We can put a befriending service in place for you. We can put all of these things in place. And gradually over the years, like the social system here was pretty good, but it's just under-resourced. And they're cutting it back more and more with each year, particularly in elderly care. So what used to be a simple pathway of you go in and you put in a referral and apply for a service and it's put in place, it's now you put in the referral, they'll bounce it back or they'll give it to another department because they don't feel that they are the right people. And then there's a waiting list for 13 months. And then eventually something comes into play. So it has shifted dramatically. And it's just really difficult for people to do because you can self-direct to it, or you can have people like me or other services and charities that will do it for you. But again, you have to know that they exist to even begin. And there's a huge population gap where people are not even remotely aware of what is existing in the country to actually ask for it. So they sit quietly. And it's the caregivers as well as somebody living with dementia that are sort of falling into a gap. They get given a diagnosis. And in Scotland, we have a government promise that for 12 months after your diagnosis that you're allocated a link worker, which is really wonderful. Your link worker links you to different services and they do referrals for you, occupational therapy, physiotherapy, getting you into the right services, the right groups to get you going. But the waiting lists are massive because during COVID, all of these systems shut down and they're still trying to clear the backlog. So it does actually, it's a challenging cycle and I don't really know what the fix is. This is the thing, like we can complain about it and we can throw shade at it, but I personally don't know what is the solution apart from more people being able to, process a lot of this work. But even then, it's where do you get the funding from? So it's a difficult challenge for sure.
It's interesting. You said so many different things I want to comment on. One was, and I'll just go on this last one with the link worker, to be able to follow up. Are you, here in the States, we got behind as well with COVID, but then on top of it, now we have less people working to do the catch up. Are you experiencing that over there as well to add on to the confusion? And
we have a massive, massive dip in recruitment. People don't want to work in health and social care. And because they don't want to work in health and social care, we've got, it's on all areas. I think across the board, there's just a real lack of it. But even consultants, specialist nurses, or psychiatric nurses, people don't necessarily want to work in that area. So it's really difficult to recruit enough specialists to process things on the medical side. Least of all have, community services in place for it as well, because people just don't want to work in that neck of the woods, which is really disappointing because it's a wonderful, wonderful role and it's so rewarding. But I think a lot of people are quite fearful of social care.
Yeah, I think part of it has to do with we've gotten so task oriented. We've taken the relationship out. Like when you had mentioned, if you don't ask the right question, you don't get an answer. People aren't going, well, maybe it's this, or how about that? Or have you thought of this? And I used to get so nuts when I sold real estate. A builder that I worked with would only answer the question asked, or if somebody asked for this, that's what he'd give them, even if he knew there were better options. He wouldn't take the time, and I'd be kicking him under the table going, come on, you have to tell people so that they can make the proper choice, with this. And we've lost that communication, it seems like, all around the world. And it's so sad because, even when you were saying, then it's 13 months to maybe be able to get in. Well, things can change a lot in 13 months, and that might not even be appropriate anymore, or something that could have been fended off now can't be. And the cycle has gotten really, I mean, it's sick and it's turbulent on so many levels, and yet there's so many great people like everyone on our panel, trying to pass information along and trying to smooth the seas for people. One thing I wanted to ask, here we're starting to bubble up a little bit more about social care, music and integrative therapies, and things like that. Are you guys doing that over there? Here, there's a lot of talk. There hasn't been a ton of action, but with a CMS guide for dementia in that realm, anyways, I think, it might be changing. But I'm interested to know, are you prescribing music versus just pills over there and things?
I think it's getting a lot better. It definitely is making a big shift. There's a lot of external resources that people are using. So it's not necessarily what you'll get from the hospital or from a GP, but there's a lot of private resources that are looking at more creative ways of engaging with people. But music therapy is on the up, which is just so beautiful because it does so many wonderful things for your brain. And the NHS, like our National Health Service, are starting to use a little bit more, but again, like only in really, really small pockets. But it is getting that message across, and that's slowly starting to find its reach. But we have things here, I think they call it Playlist for Life, which was put together by, I can't remember her name. Magnuson was her surname. Her father was Magnus Magnuson, but anyway, she put together Playlist for Life, and that was something that was very engaging for people. So there are small things that are growing, but they could get much bigger. Like, it would be wonderful if they got much bigger.
Yeah, I just think that social connection piece is so important, and we seem to be falling down with that. And, when you take out that isolation piece and people can share stories of what's working and not, that kind of plugs some of the holes in the systems, because you've got a lot more arms and legs out there, searching things down and finding out what's realistic and practical, not just process oriented. So
Yeah.
Thank you, Donna. Really appreciate you being with us and staying up late to participate in our show today. Lance, I'm going to throw it back to you.
Malika, I'm going to go to you. Thank you, Lori. Malika, you're a social worker, so you might have some interesting insights that you could share with us. I want to talk about what are some of the most common challenges you find that seniors are facing when interacting with healthcare bureaucracy. So this could be things like, paperwork, understanding benefits, and just navigating different healthcare providers.
Mm-hmm. So, Lance, you pretty much said it all. You said it all there. You kind of stole my thunder a little bit. But yeah, I think I'm a social worker, and I'm also a geriatric care manager. So that's why people hire us. They hire us because, like I said earlier, we put together those puzzle pieces. There's so many, just imagine the questions you have, finding a doctor, following up, all of these things, the puzzle pieces dumped on the floor, and you have to put these all together by yourself. It is, and a lot more people, whether you're a formal or informal caregiver, you're finding yourself in roles like helping the neighbor, schedule appointments, or make sure their prescriptions get there. So I think it's just in the same advancements that we've made in technology with portals, healthcare portals, and all of that, it's still like understanding what goes inside of there, or what questions I need to ask when I'm at the doctor, or did my other doctor communicate with the other doctor? So I need to communicate this report to my primary care physician. And I have a perfect example. I was with a client last night at the ER, And they called me, the PCP called me primary care physician. There we are using acronyms. The primary care physician called and asked me, is there anything we need to know about last night's ER visit? Now, imagine if my client was there by herself. Who would they have called to say, hey, here's the total recap? They even wanted to know what prescription she was prescribed because there's a delay in getting the information to them. And just reversing back, even while we were at the ER, they wouldn't let me go back for part of it. But when she was being discharged, I went back and I was the one that said, hey, can we redress the wound before she leaves? We've been here 8 hours. Can we at least send her home with a new, some gauze on her leg? Can we recap the instructions for cleaning it? Things that are so important and really count towards those rehospitalizations. So I think with a lot of this, for it to be important to people, because of, like we've already mentioned so far, it's very much a business component to it. You really have to be able to articulate and share how this impacts the bottom line sometime for people even to see it as a priority, or, there's nothing that builds more empathy than having your loved one tied up and no one's paying attention. So a lot of times I see that things are just check boxes, and you really need that advocate, whether it's paid, unpaid, social worker, who is patient, because a lot of times you're repeating yourself, you're making several calls, you're making sure this person knew what the last person said, and they're telling you to call back again. So someone to really take on this kind of as a full-time role.
Right. So, what advice would you give to families that might be listening or watching this about how they can better navigate like some of these insurance issues related to the care for their loved ones?
Okay. Some practical things like take notes. Take advantage of the artificial intelligence. I think that's something that caregivers need to pay more attention to. For example, there are virtual assistants. There are companies that have virtual assistants. If you can't have a geriatric care manager, that maybe that's out of the budget, but you could pay maybe a virtual assistant to coordinate those appointments and ask the questions and take reports. So taking notes is very important. Connecting with your local office on aging or whatever your area has in place, just to see what the basic resources are. You may be missing out on some things there. And also getting help, building your support system. So that could be paid or unpaid. I think that a major barrier that we have here is the wealth gap, because not everybody can sit and hire a care manager. But if you can hire a care manager, you have the resources, you work for it, please hire somebody to coordinate everything. If you can't, start tapping into your support systems. I've really seen neighbors step up. The lady at the front desk, I'm telling you, over my career, it's just been amazing. If you didn't tell me any different, I would think they were family. People in your faith community, somebody that can have your back as you're navigating and kind of making somebody CEO that may not be family or friends. So those are my immediate tips. And just ask questions where you don't know. Tap into podcasts. A lot of podcasts like this one right here and All Home Care Matters. And it's a slew of podcasts out there. And you'll be amazed. You'll find somebody on that podcast that resonates with you. Reach out, even send them an email and say, hey, I saw you on here. Let me find out if you can support me. Or if not, they'll probably guide you through the process. So Those are a few things, but I think a good start.
Yeah. I want to talk about something that we encounter quite frequently with our company, and that's when seniors, and they're not always necessarily seniors, but a majority are trying to apply and receive government assistance. How can that be simplified for seniors or for families in general?
If I had a magic wand, how could it be simplified? Or, I think that the amount of calls you have to make is ridiculous. And maybe we'll hear more about this on the call. I mean, as a care manager, just calling an office, I can log 30 minutes to an hour easily, so it's kind of sad, but you have to keep calling back, and you have to, like I said, make yourself, personify yourself like, look, I'm not just one of the 300 callers you had today. I need this resolved. So I think simplifying it, they've added technology, but it's just not sufficient. You need an assistant for the technology.
Right.
So I think that's why we have to be creative as caregivers. I'm also a long distance caregiver. And so for me, it's frustrating because I'm like, I've called this place 5 times, I've texted, I've emailed, and I do this full time. So what gives, So I think that really looking into the AI technology, like I said, I think that's something that I'm starting to recommend more to kind of help caregivers circumvent what's going on. So I don't know what to say about that. I hope technology improves, but it's just tough. And occasionally you can get a name of somebody. That's my favorite, who really sees you as a person, and you can call and ask for Mary, and Mary will help guide you through the process. But Marys are few and far between. So you really have to have an advocate.
So let's talk about that. Let's say you can't reach somebody that you're trying to get a hold of, and a lot of seniors are kind of hesitant to even explore using any sort of technology because they didn't grow up with it. It's new. It's kind of foreign to them. A lot of our homes, the seniors don't even have internet because they don't use computers, or, and they still have the old, flip phone, if they even have that. What other resources and educational services would you recommend families and caregivers and seniors look into that might give them some more substantive, resources to help them?
Mm-hmm. I think just first of all, identifying the organization that you're working with. Is this a nursing home? Is this a hospital? Is this a local case management agency? So first of all, if you don't have any technology, but you have your phone, that's something. But if it's a nursing home, for example, you need to know what's the buzzwords? What are the terms that are going to get the nursing home's attention? And oftentimes it's ombudsman. Like, okay, so do you know what the ombudsman is if you're a person or you are in a nursing home? Because all that takes is a call and leaving a message and something, and they'll get back to you, or they'll come out to your facility. So sometimes it's just knowing the pain point. All of us have pain points. Hospitals, for example, let's go back to the nursing home example. If you have an issue, you may not need necessarily an attorney or even like adult protective services or what you're thinking of. But if you know, hey, the pain point for a nursing home is for me to call the ombudsman, you need to have the ombudsman on speed dial. I had another client last year who called. They were in the hospital. The doctors weren't listening to them. They believed that race was involved. It was a very complex situation. They didn't know that they could call the patient advocate. So not only did I get I was involved as the care manager, and I was able to they thought I was the family member. So I was able to see firsthand that the family was telling the truth. Yeah. And then second of all, I immediately got the patient advocate involved. And then I'm telling you, this specific situation, we were all in tears by the end of this meeting with the patient advocate, including the patient advocate, because they acknowledged that what the family was saying was actually true. So sometimes you just got to know, okay, what's the hospital's pain point? Once we said we wanted the patient advocate number, people were coming in and out. What do you need the number for? What do you need it? Like, what's going on? Can we do anything before you call them? Like that type of thing. So it's not to say like, give me the manager, but it's after you've done everything you can. It's like, hey, no one's listening. So I need to get in contact with that organization's pain point. And that's their contact that oversees them to make sure they're doing everything right and efficiently and ethically.
Real quick, before we go back to Lori, Malika, would you share, just for our viewers and listeners who may not be familiar, what the ombudsman is and where they're available at?
Yeah, so it's an ombudsman with every healthcare organization. So you can call them and let them know what's going on. They're your advocate. They're that outside person that comes in and says, hey, so what's going on? Like, oh, my mother hasn't been changed, or they're not answering the call bell, or we asked for this and they didn't give it to us. So those are the people that you can call and say, hey, they're kind of that mediator in between.
And they're impartial.
Yeah, they're impartial. They're making sure it's okay. And I do encourage families, like, make sure you did the steps up. So sometimes the ombudsman's not needed, because the first thing the ombudsman's going to ask you is, well, did you let anyone know? And if you call them straight, then it's like you didn't even give the organization an opportunity to address or fix or make this right for you. So you want to kind of, I call it, build up your paper trail. You want to build up your paper trail to let people know, hey, I spoke to Susan, the DON, and then I went to Amy, the social worker, and then I went to the administrator. And you may not go to all three of those people. Maybe the DON is the straw for you, because I don't know how serious the situation is, but you can pick up that phone and call the ombudsman and say, hey, this is what's going on. I need you to talk to these people because I'm upset. Yeah, and you don't have to be proper or prim. Like, just let them know what's going on. Let them know how upset you're about it. And if they don't do anything, it's somebody above them. But in my experience working in nursing homes and healthcare, the ombudsman, that's their full-time job. They're pretty responsive, and they have to report and give an account to what they did to try to resolve this.
Right. Thank you so much, Malika, and thank you for being here. It's always good to see you. Lori, we'll go back to you.
Wow, Malika, you gave us such good information there. And I loved, you don't know the terms to ask for. You don't know. And so where do you go, and how do we make those things easier? So thank you so much for sharing. Mary, I want to go to you. I have been absolutely amazed at your resilience and persistence in care. You deserve that title of CEO of the Roger Fisher Care Association, that's for sure, and do an amazing job. And one of the things that I really wanted to highlight on this was what families actually are going through, getting that voice heard. And you have maneuvered everything from, like you said, the VA to the regular healthcare system, deciding to place your husband. You have just been this bright light within our support group and freely sharing information. So to me, it was really important to have you on this show to share some of your insights. So there's so many things. I mean, we could talk for days on this topic and all the little situations you've been through. But can you maybe identify 3 areas that you just about pulled your hair out over as a person trying to maneuver the system? And,
wow.
and if there's anything that worked really well, mention that too, because I know we're kind of beating up the system right now.
Yeah. Well, thank you, Lori. A few comments. One, I feel really lucky that my husband was diagnosed in 2018 before COVID, because it was so much easier to get good information and free information. And so the public library had a free monthly session at COVID. It ended. It's come back, but it's now in a city hall, and I don't think people even know it exists. One of the first courses I took was called Shaping Your Future. And one of the things they had us do is write a timeline, significant timeline of the different things we were going through. And I did it. And thank God I did, because I've been through 3 general practitioners, 3 neurologists. And I can just give them, this is when this happened. This is when he was hospitalized. This is this situation. But in terms of frustration, like, it took me aback, but when I really realized it was going to be Alzheimer's, he wasn't just going to have mild cognitive impairment, it struck me as wrong. But what I was told is get a good financial planner and a good elder care attorney. And I was like, whoa, that's scary. But I did it, and I'm glad I did it, because I want to say for all of us who are caregiving, especially for a spouse, but for a parent, it's like, one, knowing the expense of it, which is, and again, I think we're at a point where we have to question whether it's assisted living or memory care. It's going to be usually $6,000 a month just for a room and utilities. That's not any of the care. And I always want to say, who came up with that number? That's been frustrating. But given, and in addition to that insanity, is with assisted living, memory care, the model they want to present to you as though this is somehow helping you is that each individual thing is a different charge. And so the staff is ticking off how many loads of laundry they do, how many meds they give per day. And so it's even hard to financially plan under that system. Plus, it sets up an antagonistic relationship between the families and the assisted care staff. So I think we have to question that model. The place I have my husband, I love, and part of the reason is they have 4 levels of care. It's a monthly rate, and the rate is the rate, because they want to put the emphasis on the care and less on the checking of the boxes. And that's unusual, but I'm hoping it will become more of the norm, because this idea of a menu of services is just, it's set up to fail. And that's frustrating for families. So those have been, the other thing I kind of did for myself is the way I looked at it is, one of the things I had to do was socialize my husband, because I kind of knew realistically I wouldn't be able to take care of him by myself all the time for the rest of his life. And so I, even during COVID, some respite programs came back. Sorry to interrupt myself, but what didn't come back were adult day programs, at least in the Twin Cities metro. And so once again, caregivers are told this is a marathon, you've got to, pace yourself. Well, it's like you're running a marathon and they decided to take out all the water breaks, Come on, people. So it's, excuse me, right now there's one adult day program, a new one that started in September. So some of my hope is, as we navigate COVID, some things are coming back, but our networks aren't together. And so, I'm impressed with, each of us on this panel. It's like, we've had to write the books. We've had to set the organizations because it wasn't there for us, And again, I'm already, now that I've got a bit more time, it's like, I got to start writing some of this stuff down for the other people, because again, something like a cognitive processing test, which is something an occupational therapist does, that has saved, I feel like it saved my life, because it's like a series of exercises, practical, and you really get a sense of where your loved one's memory is at. And you really get a sense of, oh, I got to change how I do things. I have to change my house. I have to lay things out differently. Well, luckily, before COVID, they already were starting through social service agencies to have OTs explain the test, give the test out in the community. Again, that has stopped, but the test still exists, but you can go to a Center for Memory and Aging or a hospital. But again, to know that exists, it's like, unfortunately, it's still on the caregiver to know enough to ask for it. And part of I have learned so much, and Lori, it's always helpful to know their language, but I have learned so much by just telling, whether it was a general practitioner or an OT, you know what I'm really having trouble with? It really bothers me. Roger watches TV all day long, and how do I get him up from the TV set? And this OT person says, well, haven't you heard of Brain Gym? I had not heard of Brain Gym. And this was after I had seen the neurologist, who didn't tell me about Brain Gym either. But it's a program on the computer that does physical and mental exercises that my husband loves, and we still do it. I take the computer over to his care center. He still does it because that's his peeps. I think that, and so I looked at it as always, how am I going to socialize my husband? So we did respite programs. I couldn't get him into the Veterans Administration runs in the Twin Cities a great adult day program. He didn't go for that. That's okay. But you start to put together what likes you have, what he has, and try to mesh it as best you can. But I think this, it's not so much feeling alone, but I just felt very blessed that I had a lot of social workers running a lot of good programs. And I just looked at them as my peeps. I looked at them as my support network. And when I came across something I couldn't handle, I just would send an email out saying, hey, what do you know about incontinence? And I would get feedback. The other thing, the Alzheimer's Association, they don't promote this enough, but it's called Alzheimer's Connect, which is kind of like a little chat line within the Alzheimer's Association. That's where I learned about superior incontinent products. It's like, and so you just learn. But the whole, the other area that I think is really hard is psychiatric help. It is out there. But whoa, I think that barriers for seniors is every senior has had one of those horrible ER experiences, which teach them they never want to go back to the ER. And I think that I don't understand necessarily if the only way you can get admitted for a Jerry Psych evaluation is to go through an ER, then come up with a system, that a callback number or something, because to try to sit for 6 hours with someone who's upset it's so traumatic, you never want to do it again, and so this bureaucracy teaches seniors, or so many seniors feel like there isn't going to be anybody to help me, so I'm not even going to try. And I think that, we who benefit from good medical providers, and they're out there, we need to constantly be looking for how can we improve whatever inadequate system we have. And I guess going with Donna's thing, it's like, it's not so much a frustration, but these wait lists. It's like, by the time I admitted I needed help, I wasn't so thrilled with the fact that I now admitted it. Well, now I'm going to have to wait, 3 weeks, 6 months, whatever the time period was. And so I always tell people, think ahead, learn what because everybody has a process. Home health has a process. There's usually a nurse's evaluation. Then they're going to match you. So that's going to take, let's say, 3 months. So if you can kind of gear yourself, it's kind of helpful, because I knew long before I needed home health that I had to get home health. And part of it for me was getting over the fact there was going to be somebody in my house taking care of my husband. It just was, I was surprised at myself what a hard thing that was for me. And then I got over it. So anyways, Lori, those are some of the highlights of the quest here.
There's so much there, and I appreciate, you kind of giving kudos to the social workers that really have these resources and things out there.
Yeah.
I see so many people sharing within the support groups too, and I know for myself, I looked at that as being just one more thing I had to do. I didn't really see it as helping me, and I was shocked at how much it helped because of that sharing. Because you learn from other people's lessons that they've maneuvered. Well, Lance, let's go back to you.
Thank you, Lori. Dr. Ann, welcome back to the show. Thank you so much for being with us today. I wanted to talk to you a little bit about individuals who are looking to their physicians for answers for their medical needs, much of which are resources needed outside of their practices or their clinics. Do you see a conflict in communication and understanding of availability, the process, and the cost, and even the effectiveness of that?
I do. Yeah, thanks for asking, Lance. It's so wonderful to be in this group where we hear from social workers and we hear from the physical therapists and we hear about the occupational therapists. And an AARP study shows that most people want to get a lot of their care from their physicians or a lot of their information from their physicians. And unfortunately, I believe that if their physician isn't informed about aging and specifically about dementia or the multitude of dementias, they don't realize that there's programming that can help somebody with early stage. And so they don't refer them out to get that programming. They don't realize that the Area Agency on Aging has all kinds of resources for them for the families, for the individual and their families to start getting hooked into evidence-based programming that is not a pill, but a program. Mary talked about that wonderful programming at the library. It takes a very activated family to get that. And they think they're going to go to their doctors to get that information. And their doctors don't know. And I don't mean to I'm so excited after hearing everybody speaking. When Malika started talking about people going to the emergency room, it just made me think about more breakdowns that happen there. You think you're going to go to the emergency room and get help. But there's a point where I'm a geriatric and palliative care doctor. At what point do you not hear that maybe you shouldn't be going to the emergency room, as Mary said, at all? Right now I'm getting calls from I call him my husband. He's my ex-husband. So they're my ex-in-laws, but we're family. We're together for years and years. And my father-in-law is living with vascular dementia and has been in the hospital now twice in the last 4 months. And I keep saying, did they bring up, I've brought up hospice, but nobody wants to hear it from their daughter-in-law. They want to hear it from a healthcare professional. Even though I am a healthcare professional, I'm really their daughter-in-law. So he's in the hospital. He's 91 pounds. He's had a pulmonary emboli. He, a couple months ago, had an MI. He's 91 pounds and he has a nodule on his lung. No one is saying, maybe the emergency room, maybe a hospitalization is not the right direction for you. So it's these kind of breakdowns. Physicians are well-meaning, but they're trained to solve a problem, and they're not necessarily thinking of the bigger picture. So they're not getting the music therapy referrals. They're not getting the occupational therapy evaluation to understand where you are in the progression of the disease, to understand when you're living well or maybe when you're shifting to dying from dementia. And it's those kinds of things that I hate to say that we hopefully we can start training physicians better. But if you think about all the things that physicians are learning, this is our area of expertise, this kind of end of life or dementia specific. There's so much nuance here that we all know. It's such a complicated disorder that affects the person living and the whole family, as Malika was saying, and the financial gaps, are tremendous. So I just think that the more we can be on podcasts like this and help people understand that they're going to have to be self advocates and that there are people out here that want to help them and know how to help them. I guess that's the message I want to get through.
Well, just real quick before I ask you this next follow-up question, why do you feel like, as a medical professional, but also as a family member who has patients in their family and experiencing what your in-laws are going through, why do you think oftentimes it seems like our physicians are in these silos and they're not willing to send them and get them a referral for, different types of therapies or discuss hospice and, talk about, palliative care as an option? Where's the barrier created and why is it created?
I think there's a couple of things. One is that we mentioned it at the beginning of the programming that the healthcare insurance is kind of dictating the way care is delivered. Unfortunately, there's this huge, there are only about 7,000 geriatricians in the United States of America. And so with the expertise in geriatric care, so primary caregivers need to know so much. They can't know everything. That's a piece of it. And I think another piece of it, the palliative care approach is, that's not the way why most physicians went into medicine. Not to, I think it is actually, they just don't think of it that way. They went in there to help get people better. And so they think of better as cured, and they're not thinking better can be quality of life. And so it's not the way medical schools are geared. Even now I have a child in medical school and he's like, "You're still different, Mom. You're different than everybody." He's like, "You don't think like my professors." And so I think it's just kind of part of it's the education. And then I think a third big thing is stigma around death.
Yeah.
There's stigma around dementia. We know that for sure. And so people don't kind of lean into that. And there's stigma around death. And that combination of the two makes it so people are not going to, it's a dark corner. People don't want to go look in.
Well, and it's almost, ignorance to their own detriment. And I don't mean the physicians, well, maybe so as well, but I'm speaking to the families and the patients, because we see this daily where I can't, as a lay person with just going into this, maybe a parent or a spouse now is having some health issues, I don't feel like I should be expected to know the things to ask for that I don't even know about. So I'm relying on this physician and putting all trust in them to say, your husband, your wife, your parent could benefit from this, that, or the other. But if nobody's making them aware of it, how can they then benefit from it?
But I'm not sure. I have to be honest with you. I've taken care of some of my colleagues' family members, and they've come up to me afterwards and said, I thought geriatricians just took throw rugs out of the house. I had no idea kind of what your skill sets were. They don't know. Right. And they were like, "Thank you for helping me reframe this. Thank you for helping my family come to grips with this." So I think they would get a lot of what I do if they were referred to a social worker, but they don't get referred.
Yeah, and
I don't think the physicians, it's
tunnel vision, right? It's tunnel vision. They're just, and I think we had
they're human. They don't want to think that someone's dying. They don't want to.
Thank you for that. I want to talk about this new guide. It's a model trying to address issues like early stage disease, early cognitive loss, and even end of life planning, like we were just talking about. Do you feel as a physician that the new guide is effective to improve care?
It's a new way that they're going to try to approach
Mm-hmm.
dementia care in the United States, much closer to what has been envisioned in Scotland, which is such a great model where they come at it from a human rights standpoint. It's so much I mean, Scotland is like, to me, like, oh, the government actually says you get a year of support in the year after diagnosis. I think that's some of their goals. They and it's just going to be started, and it's being piloted. So we don't know that they're going to do some demonstration projects to see if this is beneficial. But when I look at the guidelines, they're really focused on caregiver education, which is wonderful. But they unfortunately are not focused on early people advocating for themselves in early diagnosis. And we know that that we are moving towards a time where people are going to be getting diagnosed earlier. We are not far from having a blood test, and I think baby boomers want to know what's coming, and they like to plan. But there's not a lot in there of what you can do to prevent. And I loved what Donna was saying, that there's a lot of lifestyle changes and things, cognitive stimulation therapy. There's ways to slow the progression of dementia. And if that's not added to the guide model, I think we're doing a disservice to people. And I think we're moving to a place where dementia could become a much more chronic disease and less of a terminal disease. Right now, I think it's a chronic terminal disease.
Mm-hmm.
But I think we can get to where we are with cancer, where cancer is a chronic disease until if it should come back. But I think we can get there with dementia too, where it won't be such a slowly progressive disease that we see now, with some of those early interventions, with more socialization that we were talking about, with more engagement that we were talking about, with better nutrition, with better exercise. There's so much that could happen, and people could advocate for themselves in the early stages. And I don't see that the guide model kind of helps with that. I also it does put in respite, but it doesn't have anything specifically on education for end of life. And so again, it's those two ends of it that I'm not as happy about. I am happy that there'll be a more holistic approach to dementia care.
Thank you. Well, when you mentioned this is being piloted, for viewers and listeners, is this being piloted just in a certain part of the country, or?
No, it's well, they're asking for it's going to be quite large, and it's going to be throughout the country. I guess it's been piloted already. This is kind of the next wave.
A rollout kind of?
Kind of a rollout, but still kind of being investigated for how effective it is, and if it's going to be, maybe like Donna said, it's the theory in Scotland, but it's not as much the reality in
Sure.
Scotland.
Okay.
Yeah.
That's exciting. Thank you so much, Dr. Ann. Lori, back to you.
Well, gosh, I just there's so much in this conversation. I just absolutely love it. So thank you. And Tracy, I want to pull you in. You have given care to so many people in your own family. And I want to address, and we've talked about this, but I think you might come up with a little different angle with hospitalizations in rehab centers, and then getting the boot, and how a family has to deal with that, and what it's really like on the other side when you hear, your person can't be here anymore.
Well, Lori, thank you very much for asking that question. I unfortunately have a lot of experience because I've had every single family member get kicked out of a care facility, out of the hospital, even rehab facilities. And it's not knowing what to do or how to ask for help. And I have to say my hat's off to Malika, because the whole thing about being the patient advocate, I had to start using that term just to make sure I could get help for my family. I would come in and tell them I was the patient advocate because, for example, my aunt had several different issues where she had congestive heart failure. She had metastatic kidney cancer in her lungs. She had only one kidney left because the other one had been removed. There were other complications with diabetes. And so she was very complicated to take care of, but not. I mean, when we had everything managed, everything was wonderful, but then she would not want to bother us because she felt she was imposing on us because she was having a heart attack at 2 a.m. And because we didn't live with her, it was like, okay, we have to wait for a phone call. We have to find this out. And so doing daily checks didn't necessarily help. So then she'd finally convince herself to call 911. And then she would go into the hospital, and then they would say, well, you have to do this rehabilitation for this amount of time. And one of the things we discovered was that if she wasn't admitted inpatient, she had a much larger hospital bill than if she was inpatient. And we had to start asking, is this inpatient or is this observation? Because if it was observation, we were paying through the nose. And also, if she didn't arrive in an ambulance, they put her off to the side where the heart issue became worse. And we had her in the hospital sitting in there during COVID, where she was on a gurney in the middle of the hallway because there were no rooms, and she actually had a clogged stent. And the doctor was so busy. Fortunately, her cardiologist was on duty that day, but the ER doctor, and I'm sorry, the ED doctor, said that he was going to do a chemical stress test. And I said no. I was sitting there right with her and said, we cannot do this. Fortunately, I had just brought my aunt food, and you cannot do that when they have food in their stomach. And I contacted her cardiologist because I had seen him in the lounge getting food at the same time I was. And so he came in and said, we have to do a scan right now, and then immediately shoved her into a closet where they did surgery to remove and it wasn't, I'm not joking. It was literally, they moved all the furniture out of the closet. It was the only space, and they unclogged her. So it was very, very shocking. Then when we got her to the rehab facility, we were told that she had used up all of her 911 calls. We didn't know there was a financial cap, and we had so many days to find her a place to live, which was literally 7 days. And so we finally found a place for Mom to help us get help finding some place for her to land. And fortunately, it was within 10 minutes of my house, which I had no expectation of. But to get her in there was also another challenge, because then when she started going on the path of dying, it was assisted living memory care. It was not full service memory care. And we didn't understand the difference at the moment. And so without a diagnosis for either hospice or palliative care, she was asked to leave. I was able to beg for them to keep her because my aunt also refused to go on hospice because she thought that meant she was going to end up like her aunt, who ended up having her spinal cord cut to kill pain, and she watched her aunt climbing the walls. So she thought that's what palliative care meant. So we had to train her as she's dying in front of us that this is not what it means, and that we will make sure she has a much better experience than what the rest of her family went through. So it was really a difficult moment to go through that. And unfortunately, I had similar experiences with each one of my family members. Fortunately, I learned enough, kind of like what Mary was talking about, where I learned enough to be able to navigate the system better with each family member because each one became more difficult.
Lucky for you, each one became more difficult. Oh my God.
Yes.
It's hard to believe. What did that stress do to you as a family member and your other family members? I think that's something that's not talked about. Everyone just kind of pushes through. But I mean, the stress levels are enormous. What kinds of side effects were you guys having as a family from all of this?
Well, I'll give my younger sister as an example, because she and I were tag teaming care because we lived the closest. My aunt was in between us. She had to actually get up the nerve to walk into the room because it was stressing her out so badly she couldn't go in there without having a panic attack. I, on the other hand, wasn't having a panic attack, but I was not getting enough sleep. I was constantly worried, and I didn't have anybody that I could talk to per se that had gone through what I had gone through. So people could kind of be empathetic, but they couldn't understand. So it was a lot harder to explain why this was so upsetting and why it was so difficult, where people were just going, it's the system, just deal with it. It's like, no, it's not just the system. There's a human component here, and we need to get her emotional needs taken care of too. And then finally, and this is a wonderful thing, one of the hospice nurses suggested to us that we have a celebration every single day that she's still alive and celebrate some aspect of it. And because she was such an independent spirit, we started it with singing I Did It My Way. And so we didn't have a death doula, but what we did is because there aren't any here that close by. So we ended up doing that because then it helped me express the emotion that were so pent up because I couldn't take care of her. And so the only parts that were really frustrating were like she was having, and this, I'm not to be disgusting, but she was drowning in the fluids in her body. And so you could hear her gurgling as she's starting to go. They refused to give her the medication because they said that only helps the family. It doesn't help the patient. So I refused to give it. And I could not convince the staff to give her the medication. And you could see her struggling where she could have actually had a little more ease had I had some more help with that. And just in calling the hospice nurses who weren't on site, they couldn't do anything to help me. They said if they're refusing, we can't force them to give it to her. So it was very stressful, and it was hard to sleep, and I never knew when the phone was going to ring and I was going to have to rush off to go take care of something.
Wow, it's really hard when you're in that dynamic and you don't feel you have a supportive team around you, that you're just constantly fighting the battle. And when you are fighting for human dignity and safety and quality of life and just peace, and you can't get that, I mean, I can't imagine, but I can. I have experienced with hospice how much it's changed over the years, from being really hands-on and right there on site to you're calling and hoping someone answers the phone, and then they have to call and reach out to wherever you are, and you hope to God those people will follow the instructions, but it's not always the case. And again, I think it has a lot to do with the stigmas and the belief systems of what hospice and palliative care have to offer, and to have to sit there and listen to that gurgling and know someone is suffering and not being able to do anything. I mean, that is absolutely traumatic. And that is, it is just so sad that our healthcare system is putting people through that on all levels. I mean, to me, there's absolutely no excuse for that at all. And I'm not going to sugarcoat that whatsoever. Thank you for sharing that. I think what we're going to do is go ahead and kind of open this up. We've talked with everybody, and I think there's so many things that we can dive into. So Lance, I don't know if you want to kick that off, or if you would.
Sure, I guess. Thank you, Lori. I'll just kind of open this up, and please raise your hand if you want to answer. But we all started somewhere where we didn't have the benefit of knowledge and experience and our expertise, if you will, that we all have at this time. What's one thing you'd like to be able to go back and tell yourself now that you know what you know, if you could? Amy?
Okay, so like Malika had said, I also have been a distant caregiver in addition to a caregiver for family in town. And I think I would go back and tell myself that it's okay to ask for help. I think when we start this journey that we think that we can do this, right? I read a book, or I ask somebody a question, or I talk to the doctor, I'm educated, what have you, and that you can do this alone. And I think that that's it's an ego thing for me, right? At that time, that I thought, oh, I could do this, but it didn't mean I was weak. It didn't mean that I wasn't capable. It didn't mean that I couldn't do it. It just meant that I could do it better. Yeah. And I didn't have to go through like what Tracy was saying, like those terrible times alone where you're feeling like you don't know, or it's okay to find it, like Dr. Ann, like finding the right provider. And it's okay to say, maybe this doctor just doesn't know, because that's just not their education, right? It's okay to start asking those questions. And I think that we fall down sometimes with that when we're going through these journeys. I mean, I even see it with my parents. They don't want to necessarily ask for help. My dad says to me all the time, I don't want to bother you. I know you're busy. I'm like, Dad, that's what I do. Like, I want to help you.
Right. Absolutely. Thank you for sharing that, Amy.
Okay. I would say, I would add, and I say this being humble and wanting the caregiver to feel that way, and even the care recipient to feel that way, that you are the expert. No one knows your situation like you do. You may not know who to call, where to go, what resource, but you know what's going on inside your body. You know what's going on inside of your home. Like Mary was very behaviorally specific on what was going on. Say those things because like they say, doctors are practicing. All of us are continuous learners. None of us know everything, and we never will. So take more confidence when you're approaching, I don't care how many degrees they have, take more confidence in saying, hey, this is what I know. This is what I've logged. This is what I'm feeling. And even if you feel like something is not right, asking for a second opinion or getting another care manager if someone says this can't be done. So just label and stamp yourself as the expert ongoing and go with that confidence, even with the things that you don't know.
Yeah, great answer. Thank you, Malika.
Anne, how about you? You had your hand raised.
I love the last two answers. Those are precious and priceless. Definitely you are the expert, and building that team, asking a lot of questions, the perfect answers. I think because I felt I knew what to do, I would like to advocate for caring for yourself. That it's such a emotionally difficult time to be processing all the levels of grief that you're likely going through when the relationship you have in front of you is changing due to the cognitive changes. So I knew better, and I let myself become a mess. I burned out as a caregiver. I changed. I went through a deep depression, or not deep. I went through a depression, but luckily then asked for the help of a therapist. Started a meditation practice, started journaling, but not until a therapist was like, look, you got to take care of yourself as well. So I would just say, don't forget to take care of yourself as you care for someone else, care with someone else.
That's excellent advice. We tell families all the time, if you don't take care of yourself, you're not going to be able to take care of your loved one. Tracy.
Well, I wish I would have known about the Share the Care program, because I think that would have saved me so much time and energy and had a support group built with me. And for those of you not familiar with Share the Care, it is literally organized group caregiving where you get friends, family, church members, coworkers, whoever it is. You organize them into weekly captains of 2 per week. They help you with everything from scheduling appointments, managing medications. Basically, you have your own volunteer healthcare team that may or may not have health experience, but everyone comes to the table with different skill sets. Whether somebody might be really good at managing money, somebody might be able to locate accommodations if I needed to take a family member to get treatment in another state. And you can have floaters that come in. See, I didn't even know this existed, that you can have floaters come in that maybe they only help once or twice a year from a distance because they have a skill set that they can loan. And then the other part to this is the emotional support that it gives, and the fact that you now, when your family member dies, you have a bonded group that will support each other for life. I wish I would have known it existed before.
Right. And for me, and I'm sure for most of you, if not all of you, that's the toughest thing. When you're going through it and you don't have the benefit of, knowledge and understanding and experience, or even the education, it's hard when you don't know what you don't know, right? My wife and I took care of my father for 2.5 years. I was actually in the middle of pursuing medical school at the time, and I had to change my entire trajectory because I'm like, for me, we never got any resources provided to us, shared with us, never had anyone discuss it with us. And we went through 7, 8 major surgeries, hospitalizations, and we had home health coming to our house 3 to 5 times a week, social worker, physical therapy, wound care nurse. And all those interactions over 2.5 years, never once said, have you looked into respite? Have you looked into these resources? Have you, because when you're majoring in, biology and, the sciences and all that, they're not telling you about caregiving, right? It has nothing to do with it. It's like caregiving is not even really, for too many times, it's not really viewed as a sector or a part of the healthcare industry. It's more of like the social care industry, which I tend to disagree. There's a lot of healthcare involved there. So like every time, and this is, 12 years we've been doing our business, I look at every family almost as like, that was a situation I was in. So we try to equip them and prepare them with as many resources as we can, because we know we've been on both sides of it, which I think does also help tremendously.
Thank you. Donna, you had a comment?
I think looking at my journey, like I also support my parents and I'm lucky that they're close by me, but even knowing all of the things that I do know in the job that I do, it follows on a little bit from what Anne and what Amy was saying. Self-care is very important, but also letting go of the perfection of it. Because just because you have resources, just because you know something, it doesn't mean it's going to work out that way. It doesn't mean that you're going to avoid burnout. You do still have to ask for help. You do still have to sort of touch base with other people and help yourself along the way. And I think that often gets just left in a bit of a gap, because if you are somebody that's working in this area, there's an expectation that, but you work in the area, you just know exactly how to do things. And I think sometimes that definitely gets forgotten, and I forgot that myself. So I think that is definitely something that I wish somebody had spoken to me about at the beginning of that journey.
Thank you. There's so many things to remember in this process, and taking care of oneself is so difficult because you're not the priority in the moment. You're dealing in crisis, and so you kind of push yourself to the side. I know Malika had mentioned about using AI, which I think is wonderful. Maybe to take notes and stuff while you're meeting with the doctor. Some people, record conversations, which a lot of times the doctors don't like. But I've always found too, an extra pair of ears, having someone else there to listen, because not only do you get their perspective, but you get that emotional support, which has kind of been strung through this whole conversation, the lack of emotional support, or feeling that you are even part of the team. Sometimes family members don't feel like they're heard or they're listened to or they're supported. And if we don't support them, how are they supposed to support the person with a chronic illness? It's just such a critical piece. I also wanted to mention, I think this was an important comment, and I can't remember who said it, but better care or, quality of life, better care. And what does that really mean? It doesn't necessarily mean I can fix and I can get rid of what you have. But how do you live life with it? And how do you do that as well as possible? And I think that is something that has to somehow get into the medical circle. I know many of the clinics now are starting to have social workers, and that helps. But again, there's a shortage of those, and they are overworked and probably underpaid like everybody out there right now. But that is such a significant piece of having things go smoothly, because doctors have 10, maybe 15 minutes with you, and to cover all these things is really difficult. So you've got to learn how to get organized, and that might mean writing an email ahead of time, getting to know the nurse versus the doctor to get the messages so that the critical things she can highlight and pop to the top. And we've talked over and over again about the stigmas attached to so much. If it's death, if it's dementia, if it's chronic illness, if that is not dealt with in this social care model, we're doing a disjustice. because we've really got to crack that nut first in order to be able to get people to think differently, to be open to ask for help, and not feel like they're less than because they need help. Most of us need help maneuvering this healthcare system that we have, no matter where we are in the world, because it's something that is constantly changing. And I'm really looking forward to seeing how this CMS guide, specifically for dementia, comes into play. That would be a great show, I think, for us in the future. Mary, I just wanted to touch base and see if you had any last comment that you wanted to make in terms of what do you wish you would have known, earlier on that you want to highlight?
I think I would have, I think in some ways my naivete kind of worked for me. But I wish that I would have known all of you and bought your books. That would be my thing to add to this.
Okay, wonderful. Thank you. To our audience, I just want to, again, thank our panel, but thank our audience for, watching, liking, making comments, sharing these conversations. They are absolutely critical. And we really encourage you to, pose questions that you'd like us to be able to tackle in the future. And please note, if you have resources in the comments, to share with others. As you've heard, that is a big lacking factor. And so if you have, I don't care if it's an article, if it's a website, if it's, a geriatrician or whatever, please list those things, just to raise and elevate the resources that are out there to be able to help you care better. And so, Lance, I'm going to throw it back to you to close up. But again, I just want to thank our panelists. What an excellent conversation today.
And I'll echo that, Lori. I just thank you to all of you for taking the time to be with us today and share your wisdom. Really, at the end of the day, it's wisdom for these families and these family caregivers. And we appreciate you being with us today. Thank you for joining us here at Conscious Caregiving with L&L, where we're tackling the tough conversations. Join us next month, where the topic will be kindness, love, and seniors.